All set, Olivia? Excellent. Well, good morning and welcome. I'm Alan Woodward. I'm one of the co-chairs of MACRMI and one of the founders, and I'm also a past president of Mass Medical Society. And I would like to welcome you all here today, some of you from very nearby and some as far away from Washington State. We have what I think will be a great program for our 5th annual CARE Forum. And it is very timely. If you are not aware, there was a great article in the New York Times today on why sorry is still the hardest word, and talking about some of the experiences recently with Sean Spicer and the United Airlines CEO. So it's a very timely topic. We think you will enjoy today's program. This is the first year we've split it into 2 sessions, an introductory session in the morning. So a couple of housekeeping comments before we start off. Both forums will be both sessions of the forum will be in this room. The exits are at the rear where you came in. There's also a direct exit behind that exit sign that goes directly outside if you hear alarms going off. The restrooms are outside to the right and then the left, and lunch is going to be across the main hallway in the Liberty Commons room. So with that, I want to talk about the objectives for this introductory session. They're quite straightforward, obviously. To understand the history first and the principles of it, and then to describe how to go about the implementation of a program. So I'm kicking it off with the history, background, and principles, and then Evan Benjamin is going to talk about implementation as the other co-chair of MACRMI. So why do patients sue? Well, the plaintiff's attorneys have told us for years that it's because you don't communicate with the patients when something goes wrong, and then they don't perceive you're empathetic or that you're withholding information, critical information to them and their healthcare needs and what actually happened in the OR or wherever something occurred. And the defense attorneys have, of course, told us you can't talk to anybody except me, and that's the only protected communication, otherwise anyone you talk to will be deposed. So just from the patient's perspective, we'll start with a little video.
In March of 2013, I was in the Bethesda Hospital for gallbladder surgery. I had some complications, was feeling some lower abdominal pain. They did order for me to have a CAT scan done, so I didn't hear anything, so I just assumed, really from the old school, no news is good news. So I assumed that everything was clear and that it was post-traumatic from the surgery that I had done. After getting discharged, I wasn't feeling very well at all. I had thought that this was the way that I was just going to have to live after I'd spoken to a few friends, and they said that after gallbladder surgery, your diet does change and you can't digest things as well as you had before. I continued not to be able to eat. I had lost a lot of weight. After quite a while, I decided that this was not the norm. I decided to go to my gastroenterologist, and I told him that I wasn't going to leave the hospital until he did find out what was wrong with me. He did perform some different tests. I came back on a Monday. I drank the barium enema. He then did find out that there was a mass there, so I was very, very upset, of course. Then I was right away referred to the Beth Israel to see a surgeon, and they did a few more tests, and they did discover that I did indeed have ovarian cancer, stage 3. Then I did meet my oncologist and went through chemotherapy. Then I had my hysterectomy, and then they gave me a reprieve, and then I did end up having more chemotherapy. While I was home recuperating from the gallbladder surgery, the place where I worked offered me some short-term disability, and I was just going over the paperwork that my oncologist's office had filled out. and they had asked on the paperwork, was there any pre-existing conditions? And they had written down that I had had the open gallbladder surgery, and an incidental finding in March of 13 that I had ovarian cancer. I had read that paper when after I had already been diagnosed with the cancer and had started to go through treatment. At that point, I was very, very upset because I was a breast cancer survivor in 2006, had been treated at the Beth Israel Hospital, have felt as though that was the hospital for me to go to, and the fact that I was not informed in March that there was a suspicious on the x-ray at that point. That patients shouldn't have to find out these things on their own. It was bad enough to know that I had cancer, but to know that I already had it back in March, and the time that I had suffered those few months were, very, very hard for me to get through.
So what is the response? Well, the traditional response of deny and defend is really the status quo. And what we know about the existing tort-based system is that for patients, it's unfair in that a small minority of avoidably injured patients get compensated. It's slow. The average time to an award in Massachusetts is 5.5 years. It's inequitable. Jury awards vary 40-fold or 4,000% for identical fact patterns in several studies. It's inefficient. Of the premiums that physicians pay into medical liability insurers, patients get less than a third typically. We also know when you get into litigation, it's isolating for the patient, and as far as their medical needs, they're often unmet, particularly in smaller communities. And what you hear over and over from patients is the thing I wanted most was an apology, and I never got one. For physicians, particularly in high-risk specialties, we know that the existing system has been expensive, incredibly stressful. We know that when physicians are sued or providers are sued, their depression rate, their divorce rate, their sudden death rate, their myocardial infarction rate, and their suicide rates all go up statistically significantly. We also are aware that once they've been sued, they modify their practice, and it motivates them to practice more defensive medicine. For our healthcare system, we know, as Lucian Leap says, it's the #1 toxic impediment to patient safety improvement. It affects the size and distribution of our workforce, access to care, drives defensive medicine, which our own study would suggest is maybe 12% of healthcare dollars, which drives unnecessary overall healthcare costs and affects the number of uninsured or underinsured. So here at the Medical Society, we figured we needed an alternative. And we needed a much better and fairer alternative. And so we came upon disclosure, apology, and offer, what we call CARE. And this was first proposed, well, first of all, it was proposed by your grandmother, who told you all, do unto others as you would like done unto you, and honesty is the best policy. But the first time it was picked up as an option, alternative option to litigation, was at the VA hospital in Lexington, Kentucky. In the late 90s, there was an article written, "Extreme Honesty is the Best Policy," by Dr. Kramen, who actually has been here to several of our conferences. The second time, and that was at an individual hospital, then it was picked up by Rick Boothman, who's in the back of the room here and has been to all of our conferences and involved in our grant. He picked this up in 2001 and implemented it across the University of Michigan hospital system. MMS got involved in 2005 when I heard about that program and was president here, and we had been thwarted in our efforts to improve the environment in Massachusetts through legislation, and said we fundamentally want to look for a different model. Shortly thereafter, in 2007, I chaired a task force that looked at all of the alternatives, from COPIC to disclosure, apology, and offer, to health courts, et cetera, and determined that this was the route we wanted to go, and got the support of the Medical Society. So we actually then conducted a defensive medicine study, which is on our website, and transmitted the findings of that and this proposal to Washington, to our congressional delegation, and to the White House. And whether it had any impact or not, we can't say. But in 2009, the president identified in August monies for grants through the Agency for Healthcare Research and Quality, to facilitate adoption of this type of model. So we applied, and it had to be an application through a healthcare system, so we approached BI and jointly applied for an ARC planning grant to develop a roadmap for Massachusetts on how we could move to this model. And then, as you'll see, and I'll talk more about it, we developed legislation in 2012 to facilitate adoption, and then pulled together our alliance to begin implementing the roadmap. So what are the principles of disclosure, apology, and offer, or CARE? It is to, as Rick Boothman articulated, it is to compensate patients quickly and fairly when unreasonable medical care causes injury. But if the care is reasonable or does not adversely affect the clinical outcome, you support the caregivers and the organization vigorously. So this is not a no-fault system. And regardless, you learn through patients' experiences and make every effort to improve the system. So this really is a fundamental change from what on the left has been the traditional system, which is remarkably reactive, is very adversarial, particularly once litigation begins, breeds the culture of secrecy and denial, and tends to scapegoat individuals when there's an adverse outcome, and results both in the isolation of patients and providers. And there was a great article by Segal Bell in the New England Journal on Guilty, Afraid, and Alone about the impact it has on isolating providers. And it's a fear-based system, and that fear of getting into a court system for 5.5 years because of a adverse outcome drives defensive medicine. So what we're talking about here is a system which is very proactive, and you'll see from our data, the vast majority of cases are identified by providers within the organization or the patient's family. And then there's advocacy for the patient. First of all, for their medical needs, second of all, for their psychosocial needs, and thirdly, for their financial needs if appropriate. There's full disclosure of the findings of your analysis of the cause of the adverse outcome and transparency. If it's an avoidable injury, there should be a sincere and appropriate apology provided by, ideally, the providers who were involved in the care. And the focus, instead of individually focusing on individual blame, is on system improvement and how will we prevent a recurrence. And finally, it's providing supportive assistance to both the patient and to providers, and trying to maintain trust in the relationships and take the fear out of the equation so physicians are more comfortable practicing and providers are more comfortable practicing evidence-based medicine rather than defensive medicine. So when we made the decision back in 2007 as this organization to pursue this option, the only evidence we had to go on was the University of Michigan. And in 6 years, as you see here, they had seen a dramatic reduction in the number of new claims and in the number of open cases. They also had reduced the time to resolve each case by 60% and had reduced the amount of money spent on the administrative costs of each case by about 60%. They had stopped buying reassurance and reduced their reserves dramatically, taking those funds and putting them into patient safety initiatives. Court cases had been reduced by about 90%, down to 1 to 2 a year, and they were providing unlimited coverage rather than 1 million, 3 million for their physicians, or 2, 5, or 5, 10. They were providing unlimited coverage with lower premiums. And as far as showing trust that the system was working, their incident reports went up about 10-fold. The culture changed. The fear was reduced. The satisfaction with practice was increased. And as the chief of OB told me from the University of Michigan, we no longer teach our residents defensive medicine. We teach them how to practice safe medicine. So having made the decision, and with this evidence, and committing this organization to move that direction, we applied for one of the grants. And again, we approached BIDMC because they had a reputation for their focus on transparency and patient safety improvement. And we'll talk more about that later. We worked with Michelle Mello, who will be here this afternoon, who was then at the Harvard School of Public Health, to develop a semi-structured interview, and then went forward and interviewed the 27 most knowledgeable individuals from all the key stakeholders, constituencies in Massachusetts. And that was patient safety, that was lawyers on both sides, that was health insurers, that was liability insurers, captive and commercial, and on and on and on. And what we identified with those structured interviews is that there were 12 significant barriers to implementing this model. And all of those interviewees provided us strategies to think about how do you overcome those barriers. And then from all those strategies, we developed our roadmap, which I'll talk more about in a minute. But the other thing we learned from all of these individuals we interviewed was that they all recognized, and this included attorneys, which was very interesting, is that probably CARE, or this approach, was the best of all options for liability reform, which the vast majority of constituents recognized was not functioning optimally. So these, of the 12, these are sort of the top 5 significant barriers, and there are a lot more, and you'd pick up an executive summary or the whole report, our initial ARC report, online. But clearly, charitable immunity law in Massachusetts, making the physician universally the deep pocket, was a big issue. Physician discomfort and lack of education on how to disclose and apologize. Attorneys' interest in the status quo. What about coordination across insurers when there are 3 or 4 defendants involved and each has a different insurer? And finally, the reporting requirements, state and national practitioner data bank, was an impediment for physician engagement. So from the roadmap, we recognized early that if we wanted broad adoption, we were going to need some enabling legislation to facilitate the process. We also were going to need educational programs for all of the major players, including the attorneys, et cetera. We were going to need leadership or champions in all sectors. We were going to need to have a consistent process, so we needed best practices, guidelines, and resources for the entities that were going to be involved in implementing this. And we needed coordinated working groups. And finally, since everyone says, oh, it works at University of Michigan, but we have an entirely different environment and it can't possibly work in Massachusetts, which every state says, and our lawyers are worse than everybody else, we clearly needed data to show that it also works in Massachusetts. And you're going to see that. So even before we put MACRMI together in the fall of 2011, we engaged with the MACRMI of Trial Attorneys, the Mass Bar Association, and Mass Medical Society, 2 representatives from each, I and the Chief Counsel from MMS, 2 from Mass Bar, 2 from MATA, to look at can we negotiate some consensus language to facilitate adoption of this, using the models that had been implemented in some other areas of the country where this had been implemented. And we actually went significantly further than anyone else. But we negotiated language to provide for a 6-month pre-litigation resolution period, the sharing of all pertinent medical records so that everyone evaluating the same case is looking at the same set of documents, strong apology protection for communication with patients following an adverse outcome, but not a license to lie. So if there are factual statements made during the apology and then directly refuted by the same physician or provider in a court of law, subsequently you can perforate that protection, but that's the only limit. And that there should be full disclosure of significant complications. So those first 4 components were all the consensus language amongst these 3 bodies. In addition, this was incorporated into Chapter 224, which was the payment reform legislation passed by Deval Patrick. We ultimately got this negotiation done the day before the bill was introduced. It was in the spring of 2012. The governor signed it in August, and it went into effect in November of 2012. Literally a month later, we started enrolling patients in our pilots. So right after we got this consensus language negotiated in the spring of 2012, we started to work to bring together all of the interested parties to say, how do we move forward with the implementation of this roadmap? And you can see there, it included the Mass Medical Society, the Mass Hospital Association, the Mass Coalition for Prevention of Medical Errors, Bay State, its hospitals and insurers, BI, its hospitals and insurer, CRICO, which is up at the top there, the Medical Injury Trauma Support Services, and Linda Kinney is here today, and Coveris, which is the largest commercial insurer in Massachusetts. And then shortly after the inception of this group, we brought on the Mass Bar Association. Also, the Board of Registration was involved, And subsequently, a year and a half after we established it and started our pilots, we added the Atrius Healthcare Group and Sturdy. And I'll explain why subsequently. And I would say that on the right there, we decided to call our program CARE. We thought disclosure implied one-way communication, and we wanted a two-way dialogue. So we called it communication apology. And we thought offer implied that it was just financial compensation that was going to be provided through this program. But instead, we wanted to make sure that the resolution was as comprehensive as possible. And for many patients, it isn't financial, it's making sure that your patient safety efforts have been implemented to prevent recurrence. So what is CARE in our definition? It's the concept of communicating with patients and families when unanticipated adverse outcomes occur, regardless of cause, investigate and explain what happens, implement systems to avoid recurrences, and where appropriate, meaning for avoidable injuries, apologize and offer fair financial compensation without the patient having to litigate. So our initial efforts as we put together this alliance were to secure funding to support it for its first 3 years, which was the duration of the initial pilots, to establish those pilot programs, to get a website up and running, which we had proposed in our ARC grant would be a resource center that could be available to anyone across the country, to develop the necessary resources to define the program and the processes. And then 5 years ago, we hosted our first annual forum in this group and in this room, and have done one every year since. We also worked to clarify the reporting requirements both at the state and federal level. And although we'd been asked by ARC to apply for a subsequent grant and did so, a demonstration grant, which would have been $3 million, there never was any appropriation for the funds that were articulated in the Affordable Care Act by Congress. And so when that was clear we weren't going to get federal funding, we turned, with this group ready to move, to local sources. And everyone we turned to supported this effort quite dramatically and quite surprisingly. Well, not entirely surprisingly, but CRICO funded the effort at the BI hospitals. The Bay State Health Insurance Corporation funded the pilots at Bay State. But in addition, we went to the health insurers, Blue Cross, Harvard, and Tufts, and they all provided funding, along with Coveris, the Mass Medical Society, and the Reliant Group in Worcester, which had implemented this type of model in 2007. We then established our pilot sites, and again, it's the top 6 that we started with. It's BI and its affiliated hospitals at that time, Bay State and its affiliated hospitals, so it's 2 big academic centers with the affiliated community centers. And then about a year and a half later, we were approached, and we approached Atrius to look at, can this model work in a multi-specialty group practice, which doesn't have a hospital as an anchor. And likewise, Coveris asked us, can you look and see if this model can work equally well in an institution that is not insured by a captive, but is commercially insured with a largely commercially insured medical staff. And so Sturdy Hospital came on board. We then established our website, and every single reference we talk about today, and I would point out that in this handout that we gave you today is a list of all of the major materials that we have developed and that are available. And they're all available on this website. And you'll see it's set up for patients and providers. And a year or so after we started, we added the sections for attorneys. There's a very comprehensive resource library. There's mechanisms to connect, to sign up for a newsletter, to request speakers, etc. So this was all set up, and I would point out that resource library where that arrow is pointing is where you can get all of these handouts. And interestingly enough, our website has won several awards. So the important focus was to develop appropriate resources. And we started out with best practices for institutions, then best practices for how you interact with a patient when something goes wrong, and then we worked with the Harvard Law School in their mediation section, and several students did a comprehensive interview process with 27 similar experts across the state, and helped us develop the best practices for patient representation when patients are going through this process. We also developed patient brochures, such as the one you could pick up out front, and procedures for a site readiness checklist and procedures for implementing this model, as well as FAQs for all of the audiences we wanted to reach, teaching slide decks for teaching, the ID badges, which are also out there, which most institutions provide for their clinical staff so they know what to do when something goes wrong. And finally, we developed the care algorithm so that each of these, each case would go through the same process. The other thing that was identified, as I mentioned, as a roadblock is the reporting requirement. And we started in 2013 and modified the state reporting requirements through a budget process. And the language of that modification is up on the website. But our criteria in Massachusetts were more onerous than the national criteria. So we also then went to, this is Rockville, Maryland, and that is a small building for HRSA under HHS where 6,000 people work, and it houses the National Practitioner Data Bank. So we asked them about how they could work to facilitate the federal reporting requirements, facilitate change to make, to get over some of the impediments we had encountered. And in the process, we clarified that in order to have to report to the National Practitioner Data Bank, there has to be a written demand for payment, and that payment must be made on behalf of the physician. We also added additional FAQs in their guidelines. Recently, we've been working to disseminate this in Massachusetts, regionally and nationally. That's why you're here today. We've completed data collection on 1,000 cases. You're going to hear about that this afternoon that have gone through the care algorithm to study outcomes and implementation. We did a one-year study of provider perceptions of the care process, which you'll hear more about this afternoon. And we've developed several additional resources and started educational forums for attorneys. And this is really where we started with the attorneys. First, jointly between MACRMI and Mass Bar Association, we developed best practices for attorneys representing patients and attorneys representing providers going through the care process. We jointly sponsored seminars, and this was at the Mass Bar Association. You see the picture there, and there's actually a plaintiff's attorney from Michigan on the screen who was talking about the experience there. We had a defense attorney, a plaintiff's attorney, myself, Ken Sands, and a moderator. And from that, we developed a list of attorneys who want to represent patients going through this process in a collaborative fashion to get an optimum resolution for the patient in a timely fashion without having to litigate, and that's on our website. We also finalized a comprehensive care implementation guide, which is available, so that institutions that want to move this direction don't have to reinvent the wheel, but it's a step-by-step program. And again, it's not just online, it's aided by assistance from our personnel. So this is where we've been, and this is where we're going. We started in 2012, so we're at 5 years. We started by gathering stakeholders, then piloting our care program at 6 hospitals, developing our website and resources to reduce the barrier to entry, educating others about care, and finally we're working to change the culture in Massachusetts around the response to adverse event, and we think we're going to hit a tipping point, and hopefully in the foreseeable future. And where are we going? We're now moving to develop our 6th best practice, which is for insurers, so there'll be a consistent process for cases that are turned over to insurers for consideration for possible compensation. And we hope to have this out this summer. In addition, we're adding additional care sites in Massachusetts. The partners hospitals have agreed to adopt this model. We're starting with Newton Wellesley, and I know there are representatives here, and Alan Kachalia, who's heading up the effort at the Brigham, and Faulkner ultimately, and then we will go through the remainder of the system. We're also working to continue regional and national dissemination. We've had several discussions with Connecticut who are interested in looking at a similar model. And we are just completing, and you're going to hear a lot about it this afternoon, our data analysis for publication. And we've also made the commitment to maintain MACRMI and all of its resources for the foreseeable future. So in conclusion, We think that compared to the deny and defend and litigate model, this is the right thing to do morally and ethically, and it's what your grandmother taught you. It's also the smart thing to do. And read the New York Times today about how you can manage adverse outcomes in a suboptimal fashion. It's the right thing for patients, and I'll remind everybody, as I did too when I had to present this concept to the House of Delegates of the Mass Bar Association, you are all going to be patients one day. We think it's the right thing to do for patient safety rather than thwarting and the secrecy, and we can't talk about it. These are open, honest discussions about how you're going to improve the system. It's the right thing to do for providers, and you're going to see an overwhelming provider satisfaction response that we surveyed. And we think it's the right thing to do for hospitals and for accountable care organizations from a PR perspective, a patient safety perspective, and all perspectives. And ultimately for all of us, for healthcare access and affordability, it's the way we want to go. So with that, I'm going to turn it over to Evan, the other co-chair of MACRMI, and he's going to talk to you about how you go about implementing such a model at your institution. Thank you.
Well, good morning, everybody. It's a pleasure to be here. Bay State Health and our insurance company has been very proud to be one of the anchors of the MACRMI Alliance and trying to really test this model and working with our colleagues at Beth Israel and at the Harvard School of Public Health to help evaluate this work. So I think you're going to see a lot of exciting things this afternoon when you hear a little more about the studies and the conclusions that we're drawing from our experience. But this morning, what we wanted to accomplish was to really give you an introduction for those who are considering really launching a CARE program or a CRP program, which is, you're starting to hear that term nationally. And so I'm going to drill down a little bit further. Alan was at about 30,000 feet. I'm going to take you down to about 10,000 feet and share with you some of the issues and ways in which, as the Alliance put forward the steps towards getting to better communication, apology, and resolution. One of the things I want to do is talk about what this looks like from the perspective of a clinician and a risk manager and a patient, and try to give you a little deeper dive into the workings behind what we've done. So we broke this down into some very specific steps. What has to happen as you are launching a CRP program? The first is the experience that we watched happen at the University of Michigan, and then we saw this again at Beth Israel and at Bay State. The first was really talking about learning about errors and mistakes and getting people to start reporting events. You'll see that an essential component to having a successful care program is that there's open and honest reporting and open and honest discussions about patient safety, adverse events, as well as near misses. And it really becomes this core of becoming a learning organization. And it's as a learning organization where you start getting reports about what happened. So the first step is really getting out to the organization and talking about that we want to hear about everything. We want to see the reports of events as well as near misses. And as you can see, what happens when you start this campaign, people start to respond. But it needs to be genuine, and it needs to be part of an effort that's really trying to move a culture of an organization. The second step in once we have learned about events is really around the communication. It's communicating directly with the patient and family about the event and what happens in that very initial conversation. Most of that initial conversation is about empathy, and it's really a direct, honest communication, expressing empathy, and discussing really what we know at the time. And what we've learned is the facts take a little while to come out. So the initial discussion is nothing more than an expression of what we know and an expression of empathy. Over time, we learn more about the risks, the causes, and we want to communicate that later. I think most folks in the room who are familiar with patient safety know if you look at a Swiss cheese model of medical errors, that for an event to actually have an impact on a patient, if there's an error, all those holes of the Swiss cheese need to line up. And it's usually on average, what we found is about 4.5 on average actual breaks in our systems that allowed an initial error to impact a patient. So there's a lot that happens. In fact, oftentimes when you hear first about an event, our human instincts are to jump to those conclusions of what happened. And you have to resist in that initial communication to the family what you believe happened and how it impacted the patient. Because when you actually do the root cause analysis, and we'll talk about how that happens, we realize how much more complex every situation is. So step 2 is really a communication, trying to resist that human urge, focusing in on the facts, and talking about what we know had happened and expressing that empathy. So a few notes on apology. There's a lot of experts in apology here, but as the New York Times article today talked about, how do you express an apology? Really, first of all, as a statement of regret. And if we believe that there's an apology of fault, when do we do that? Pretty early on in some of these cases, we know there's an apology of fault, and so we will actually advocate for not only the regret, but the apology. And so these are very subtleties that we've learned over the now 6 years of doing care, of when is it a statement of empathy and regret, and when is it an actual apology of fault. The third is really around documentation, making sure that communication and what was said is documented. And that's really, who was present, what were the results of the conversation, how did it go, and what was said in terms of an understanding of the event. And step 4, rather generically, it's really around checking back with the patient and the family at a time when we've learned more, and we're bringing together then what we've learned, and particularly the focus on system improvements. And Alan had mentioned, the things that patients want to hear after they've been involved in a medical error are, first of all, the apology, but also to know what was learned, and that becomes very important later on. The initial conversations is about an apology and what happened, and what's happening to me, and how am I being cared for now. And later, the findings and the system improvements that are putting in place that would mitigate further error becomes more and more important. And you can see how that would happen over time. So those are these 4 steps. We've tried to create a simplified approach, and we've got algorithms in place. They're online. Actually, in your packets today, I'm going to share with you one of our algorithms, but there's the first algorithm, which we call the CARE algorithm, and it talks about how we define a case and how we move forward. So we have 2 basic algorithms. One is an overall filtering of where a case enters the system, and then we have a second algorithm which really defines the case as what we refer to as an insurer case. And I want to take you through the thinking of what that means. So in that guide there, you'll see how you define a care case. A case can enter from the left there, where it's coming in when we're hearing about it through our own systems. And that's where the reporting becomes really important. And having a culture of safety, a culture of psychological safety, where people feel comfortable talking about errors, not that they are reporting on their colleagues, but we're hearing about these events. So we're hearing about these significant adverse events, and they're entering on the left. And what you can see is what happens very quickly is there's a central control, there's a central quality department. And this varies, it's slightly different at Bay State than it is at Beth Israel, but what is consistent is a central patient safety department, which is hearing about those first events and making sure that the support services are being activated. That's the first step. The support services for the patients, for the families, and guiding that initial conversation. Then it's really that communication with the patient and through the patient safety department, working with the clinicians in that guided conversation. And then we move on to an internal investigation, which is a little more robust at that point, and we're looking at what actually happened, doing that root cause analysis. The other point of entry is on the right, where cases come in really through a litigation notice. So we're hearing about it first from the patient themselves through the legal system. In Massachusetts, of course, this is a pre-litigation notice because, as Alan mentioned, we have this 6-month cooling off period, and so the pre-litigation notice may be the first time that we're hearing about it. That, over time, has really been interesting in our experience. The number of cases we hear about from the right side, the point of entry, has gotten smaller and smaller as the reporting and the culture has really expanded things on the left. And that's exactly a positive result of implementing the CARE program, is we're not hearing about these errors through the legal system, through the patient, without having it identified earlier. So then we ask 2 basic questions. So if you drill down a little bit there, we want to know what happened. So at the point of doing our internal investigation, we're asking 2 very basic questions. And this is a typical risk management approach to understand what happened. The first is we focus in on the standard of care and ask, was the standard of care met? And if the answer is no, or we're not sure, we then are asking the next question. So the first is, was the standard of care met from everything we've understood, either from a system point of view or from a practice perspective? Was the standard of care met? No or unsure, we then ask, well, was the patient harmed as a result of the standard of care not being met? So 2 basic questions. If in fact the answer is no and yes in our protocol, we are now then initiating our care insurer protocol. And this is where we know that we want to move very quickly towards discussions about resolution. Okay, and that's where, in fact, this afternoon we're going to be having a panel about what happens in those conversations as we've moved to this case now being an insurer case. And what's the relationship between the patient relations department, patient safety department, and the risk and the claims. So this is where these cases now, they meet these 2 criteria, they're becoming our cases, our insurer cases. So the cases then are reviewed by the insurer. There may be now an external investigation as well, or an external evaluation where the insurer may say, we're moving towards resolution, we want a better understanding. There's already been an internal investigation. That's usually been the internal patient safety departments. But now the insurers may be asking for external experts to really understand, what was the violation? Was it a true standard of care violation? What are the issues? And then beginning to start thinking about, in the old system, in a court of law, what would be compensable and what would that compensation look like? And so this is where the insurers are moving on. We're doing an investigation. There may be external. And we're now proceeding with discussions back with the family and the patient, but this time the insurers are involved. And this is where we're actually encouraging patients and families to have an attorney. So the importance of what Alan had mentioned earlier, as we've developed these best practices, is what's the role of the attorneys in this situation, and how do we actually encourage particularly the plaintiff attorneys to work understanding, they need to understand the care work that's being done, that it's a slightly different approach. And so the work of MACRMI over the past 2 years has really been focusing in on these discussions and what the role of the plaintiff attorneys are, and how we can even develop lists of those plaintiff attorneys that understand what's happening. So now we're having conversations directly back with the patients, with the insurer, with a patient's attorney that we're encouraging, with the providers as well, from those initial providers. And this is where we're continuing the formal discussions of apology. We're coming back to the system improvements, that's still part of the discussion, but now we're talking about compensation. So what does this look like? This is a very sketchy timeline. But after 5 years of doing this, this has remained somewhat consistent, but that's why you see these large ranges in the months. But obviously immediately within those first 24 to 48 hours, when these cases are entering from the left side, where we're being alerted, we're activating support services immediately for the patient, immediately for the providers. So peer support also is being activated very early as well. And the discussions with the patient regarding the error and regarding what the known facts are happening that initial 24 to 48 hours. Within 2 to 4 weeks, we've done the internal investigation. So that's where, that pause at that 24 to 48 hours, not to jump to those human conclusions of, I know exactly what happened, is pausing, and it's doing that internal investigation. It's looking at the algorithms that we've put in place around just culture, understanding systems, understanding how many errors actually were involved to really understand what was going on in that root cause analysis. And then our patient safety and patient relations are really maintaining contact with the patients. And that becomes really critical, that it wasn't just that initial conversation. Within 2 to 4 weeks, we're continuing the relationship and continuing those conversations, saying this, hey, we've learned more. And the patient and the families are feeling that they are still connected and we're still working with them. Telling in time what we know. 1 to 3 months, we're now looking at, we've passed this on if it met those 2 criteria that I shared and it's becoming an insurer case. We're now looking at the insurer getting involved. So at the same time, we're having the organization step up their role in terms of system issues. We're looking at continuing that communication with the patient and making sure that the handover to the insurer is going smoothly. And that varies. At Bay State Health, the insurer is, it's a self-insured captive just for Bay State Health. And there's a very tight relationship between patient safety and the claims. And the claims folks are involved actually very early. At Beth Israel, we had CRICO involved. It was a little more of a wall that the initial investigation was done, and it was sort of pushed over to the insurer and not quite as tight, so it's very different. And then, of course, when there's a commercial insurer involved, like Coveris, there's also a slightly different relationship there, and that's why these timelines, these 2 to 5 months where we start talking about the insurer reviews, is quite varied. But the most important thing is that the insurer understands all this and they are consistent with the approach that we're providing and understand the process in this timeline. By 3 to 6 months, we've had the insurers engaged. We're still keeping patient relations involved, patient safety, except now we have the insurers, and we may have some lawyers involved, and we're concluding those discussions and actually making even final offers. The experience of moving from an adverse event that caused significant harm to a final offer that's accepted within 6 months is an incredible success. And that we're starting to see more and more. So from Alan's perspective, from a patient and a family, within 6 months, hearing about the system improvements, hearing the apology, and getting an offer, it's all over very fast. The same for the providers. Having, Alan said, 5.5 years of depositions hanging over your head. My colleagues, I know so many folks who actually want to walk away from their practice of medicine. 5.5 years of worry and depositions. Within 6 months, this is resolved, and we're now talking about system fixes and peer support. So that timeline is incredible. It's probably the biggest benefit that we've observed from all this. And you'll hear later about the financial impact and how this has worked. So let me share what this would look like from the patient's perspective. You heard the video earlier.
I was very, very surprised that the doctor, the head of surgery, wanted to speak to me. I had a meeting set up with Jeff, and we met in a conference room, and the doctor was more or less very, very sympathetic to me, which I thought was like the last thing I thought a doctor would ever, because the doctor is always right. At the meeting, I did learn that on the CAT scan, there was a mass on the CAT scan, and that I was to have a pelvic ultrasound. Nobody came and informed me of that there was anything suspicious on the CAT scan, and I was discharged from the hospital not knowing anything. They more or less admitted that there was a mistake, and as far as them coming right out and saying that there were two different discharge papers. The discharge paper, which was the one that was the final one that was signed out when I was discharged from the hospital, was the one that meant that the mass was more serious than the one that another doctor had said. There was a contradiction as far as one saying it was more serious than the other one, but the one that was finalized, that was signed off when I was discharged from the hospital, was the one that said that it was more serious of a problem. So evidently nobody read that discharge paper to inform me or anybody that there was a more serious problem than thought of. They did talk about how things are going to be changed as far as the protocol. Doctors do have a lot of stress, that they were breaking it up between the residents and the emergency doctors. We're going to have different people to go to as far as discharging and things like that. And to also that they, it's something that they don't want to keep continuing. They want to be like a role model for other hospitals. I felt very, very good after leaving that meeting. I felt as though they understood how I felt, and I did want to say that the doctor was very, very kind and made me feel at ease that I did have a reason to be upset. I felt as though that, I'm a meek, mild person. I felt as though maybe I might be a little role model for other patients so that this wouldn't happen to them for what I went through. I don't think I could have gone without my lawyer because, again, as I said, he just was for me, rooting for me. He was my cheerleader. He just made me feel that I had a purpose and that he was standing behind me, helping me out, just being my little angel over my shoulder. And I know people, whatever, and I just knew he was the guy, and then I felt so right away that I could talk to him like a regular person would be intimidated by a lawyer. Most people, you know what I mean? They think, ooh, lawyer, or, a big head surgeon, that white gentleman doctor that I spoke to, he made me feel so at ease. And I am cancer-free right now, and I'm under very, very good care of my surgeon and my oncologist. I go every 6 months, and they do the C125. It's a little nerve-wracking, but so far it's in the low numbers where it should be. I'm doing very, very well now. I just signed up for a pottery class, something I've always wanted to do. I've since retired. Looking forward to the spring where I can try to do some little bit of gardening. And then also in July, my father was from Ireland, and my brother and myself are going to a wedding in July, and for a wedding, and I haven't been there since when I had been diagnosed with breast cancer in 2006, so I'm looking forward very much to it. I have many, many cousins and aunts and uncles in Ireland.
So what's also, I think, what you're hearing there is a retention of trust within the system that she was cared for, which is another component of care that it's difficult to study. We try to actually, in one of the papers which is being published, understanding the perceptions of the patients after they've been through an adverse event and the arc of emotions that occur through the event, and how the communication, the apology, the resolution, the compensation, and the learning about systems, how that impacted their relationship with their providers and with the health system itself. And I think what you're hearing is that she had a lot of all those full emotions of that arc, and yet ultimately stayed with the system and retained her trust with the system. So what else is important? Things that we've learned over time, leadership buy-in. Obviously, leadership is setting the tone for the organization. People need to hear that we are not in this environment of blame and shame, and we're not hiding, that we are a open, transparent organization, and we want to learn about all events, and that leaders need to help walk the walk and talk the talk, that leadership is absolutely fully supportive of a care program. I mentioned briefly this idea of a baseline culture of safety. To me, this is the most important thing. It is the underlying foundation. Without it, I actually have told other organizations, do not move down the path of doing communication, apology, and resolution. You will fail. That is probably the most foundational thing. You have to have a baseline culture where the organization has had the comfort and understanding what is involved, understanding system thinking, understanding the role that individuals play in interacting with the system, that there's honest conversations, that you've created a just culture. We've adopted Reason's algorithm, it's very familiar to some of you, about how to think about a medical error. Where does culpability come in? And when do you actually coach someone who's been involved? When do you counsel them? And when do you hold someone accountable in terms of their job? And so having a just culture and understanding the levels of culpability and the systems, these things have to be in place. Otherwise, the reporting won't increase, and you can't have honest conversations to patients and families if you haven't been having honest conversations with each other as staff. It's important that there's resources for this. We actually had to add some resources, both Beth Israel and Baystate, in terms of a program manager, because the number of cases we started managing went up. And you'll see later that total payments didn't go up, but the number of cases went up because we're telling everyone we want to report, we want to apologize, we want to have conversations, and you have to manage all these cases. So it's the right thing to do, but it did ultimately require some added resources. Not a lot that it changed the equation of the return on investment, but enough to recognize that there will be some required work that needs to get done. Commitment from risk management and patient safety. In 2007, we started at Baystate on our own a apology and disclosure program. I actually thought we had an apology disclosure program, and we wrote a paper about it in 2008 about our experience. I realized once we joined with Beth Israel and we started holding each other accountable to this, that we didn't have an apology and disclosure program. What we had was a selective apology disclosure program, which was in the cases we knew we really blew it and we're going to be sued on that case, we'll go down this path. But it wasn't a true care program where we're learning about all cases, we're communicating, we're apologizing, and we're moving to resolution on smaller cases. The average payout for most of our cases, is under $100,000. And what we had before was a selective program. And so risk management, patient safety, they need to get this, that this is we're all in, and it's not a selective program. Support, I think, support for the clinicians, having a peer support program, because we're working with clinicians who are sort of uncomfortable. One, they were involved in an adverse event. We're sitting down and coaching them on how to do an apology and communication. They need the proper peer support, and then the patient support as well. And MITS has been a tremendous resource, a great resource regionally, nationally, to really link our patients, sort of keep an outstretched arm length in terms of offering the support by going through MITS has been a great way to have the support for patients. So consistency, I think I covered that in terms of the rigor of the events as well. Consistency of how we do our analyses, leadership, and the teamwork. And I think that's the biggest thing is we have different departments throughout the organization. They actually bringing them together so that there was a consistent approach. Patient relations actually reported to one part of the organization. Often you'll see in organizations that risk reports one place, quality and safety to another, and having a teamwork that we're all aligned around this regardless of sort of reporting, and that could establish different philosophies in an organization. I mentioned the support and reinforcement, the re-education. This is a constant education. It doesn't go away. When you've got a big, complex organization, you have to keep it alive. You have to be talking about it at every single event. It's now just in the protocol, the checklist. What was the care protocol activated? When was the conversation? When's the follow-up conversation? So it's got to be consistent and constantly reinforced. So I'll stop there. I think Alan can come up and join me, but thank you very much for your attention, and we've got some time for questions and answers. Assigned seats.
Assigned seats.
Do people know Melinda?
So I'm going to join them up here as well. I'm the program manager for MACRMI, and I also helped implement the program at Beth Israel Deaconess when it was first started.
Melinda's the glue that has kept MACRMI going since its birth, and we could not have done all this work without her.
Well, thank you
She's
very
the
much.
organizer behind the organization, and she's the one who's put together and implemented this program today, as well as our previous 4 forums and our Mass Bar Association presentations, et cetera.
Thanks. So if anyone has questions, they could come down to these mics. I just want to warn you, these are being recorded for our website so that people that couldn't be here today can easily watch them. So we will only see your backs, but I just wanted to let you know. And if you want yourself cut out, you just come and talk to me and we could do that. But if you have any questions about how we got MACRMI started, how to implement this, you have questions about what Evan said about starting a program, you're just new to the idea, just please come down to the mic and we're happy to chat. Don't be shy.
Well, I'll get it started first by thanking you. Those were really great, succinct, wonderful presentations. Thank you. So it sounds like everybody won except the lawyers' paychecks. And I was wondering how you avoided the opposition, because I can't imagine that the attorneys are making as much money from the system after this is successfully implemented than they were before when they were getting contingency fees.
So I will take that one. And actually, Rick had started a discussion about this when we talked to him in University of Michigan and how they did it, and how do you deal with the plaintiffs and the defense attorney. And he actually put together a CD, a DVD that he uses for recruiting, which incorporated some testimony from some of the attorneys. But on the plaintiff side, they're actually, when they understand this, quite supportive, because a plaintiff attorney will spend $50,000 to $250,000 teeing up a case to go to court. That's what they have to invest. They get a 1/3 contingency. They have to get $750,000 to break even. So this is really a jackpot phenomenon for them and a very high-risk proposition. So the alternative of sending a letter to Bay State or a hospital that is or organization that's involved in this, and that will precipitate this type of internal investigation and transparency about the findings, is very positive for them. And in essence, often they're involved when we've already said this was an avoidable injury. And so really what we want the attorneys involved for is to make sure that the resolution for the patient is fair and a fair compensation. So they don't have to invest the 5 years also going to court. On the defense side, and you'll see, and I would actually encourage you to go through our website. You can connect to the Mass Bar Association presentation from 2 years ago. We're actually going to do another one in May, and we did one out for the Hampton Bar Association. But the reality of the situation, you'll hear both from plaintiffs and defense attorneys about the benefits of this approach. So initially there is a lot of resistance. And once they really understand that this is an open, honest, transparent process and that we want the patient to have a plaintiff attorney involved to represent their interests going through this. And you heard from Tricia the benefits that she got from it, and you're going to hear more this afternoon when we talk about patient feedback. It's very important that attorneys be involved and that we don't want them just to be looking out for the financial compensation. That's a critical component, but it very much helps, as you heard from Tricia, to have a confidant, someone who's on their side, who they can talk to openly about what is really going to make me feel better about the overall outcome. And that's why we really want to focus on resolution.
It also helps them in that they can take cases that have a smaller value, right? So typically when someone comes to them and they say, this injury is not severe enough, even though something may have happened here, I can't invest this much money and time in this. But if they come to them and say, I've had this offer, could you come and sit with me, and we can maybe work on an hourly rate for something that would be smaller, they can actually help that patient to receive justice in a way they couldn't before.
The other, I think I would just add is, sort of ironically, the defense attorneys are probably taking the biggest hit because the areas where we're seeing some of our biggest reductions in expenses has been in defense expense. Not so much, the compensation and the payout is one thing, but we're taking so few cases that we require the services of a defense attorney. So, ironically, it's more so on their side that they're taking the hit because of the number of cases. Mm-hmm.
Thank you very much for your presentation. I'm Patricia Falco, OBGYN, and I do a lot of work in medical malpractice tribunals. As many of you know, 85% of obstetricians are sued within 10 to 15 years of being in practice. This is more of a comment than a question, so I apologize for that. I will keep it short. My wish list is that there would be a lot more training in medical school and residency about how many systems are involved, and not only moving beyond this culture of shame and blame, but into a lot more understanding of the systems. My wish list is also, in addition to this education about systems, is that I wish we would give to patients at the end of hospitalization a kind of the way the movies have where they roll the credits and you see the hundreds of people it takes to produce something. I wish we would give them a sheet that says, these are the people in the lab, these are the people in imaging, these are the people in admission, these are the people in medical records, these are the people who are your ward nurses, these are your surgeons, these are your pharmacists. I wish we could help patients to understand how much systems are in place rather than automatically blaming doctors as captain of the ship for, whatever happens in that organization, and where the organizations have this limited cap on their liability. Where is their motivation to fix anything? Thank you.
Well, it's a good comment. I will say that the approach that we've taken actually really complements your statement, because if we look at our approach, once we actually have an adverse event and we do our internal investigation, we are taking really the bull by the horns and then sitting down and saying, this really was a system issue. This was not a physician issue. And because without this approach, patients' only course that they can actually work on is by suing the physician because of the way our tort system is set up. And so by being proactive, and I would say 95% of our compensations we're paying on behalf of the system and not of the physician. And so therefore we're not required to report that to the National Practitioner Data Bank, and the system is paying it based on the system. So it actually complements your statements. Unfortunately, this is where the tort system has come, and our reaction to it really is not only better for the physician, but it's actually better for the system and the patient.
Mm-hmm. And it's better for them to understand the complexity of the system, like you said. If they're just going to go to court, they're probably going to blame that doctor for the rest of their life. But if they meet with us, then they're able to see these are all the different places where things may have gone wrong, and these are all the people that work together to bring your care to you. Then that's actually really helpful for them to understand what happened and how we're going to fix it.
And I would say from the inception of MACRMI, we had the Mass Hospital Association involved because they recognized that as we move to accountable care organizations, it isn't going to be a finger-pointing exercise where one person or one entity is going to be the only pocket. And part of that statute on Chapter 252, I didn't really get into, but part of it was to raise the cap on charitable institutions from $20,000 to $100,000 for medical liability cases. Now, you could still say that $100,000 seems a small risk, but they're definitely engaged. And part of the premise of this whole program is that the institution or organization will be involved, not just the individual. And in fact, we're working with Coveris, the largest commercial insurer now, to look at how solo and small practices can work through this process with their insurer where they don't have the infrastructure of an institution to support them. So there's several moves, but I think we all need to recognize it's going to be enterprise liability, not individual liability. We're going to be moving towards accountable care organizations, and organizations are going to have to be accountable for their outcomes and their patient safety. And so this really just synchronizes the concept of a just culture and many of the other, and patient engagement and patients directing their care, patient-centered care. It all is integrated, and this works with that new vision, I think, of how we're going to deliver care in a better, safer, more cost-effective fashion.
This side.
Hi, Michael Sinha from Brigham and Women's Hospital, and I just wanted to add to the comments you made about the plaintiffs' attorneys. So I was at the annual Health Law Symposium the Massachusetts Bar Association held last week, and their president, Jeff Catalano, made some very positive comments about MACRMI and about the role that mediation and resolution plays in plaintiffs, and just helping to, as we said, get them compensated for their injuries in a fair manner. And his point was really the more plaintiffs' attorneys learn about how this process works, they're going to come around.
Mm-hmm. And Jeff has, I'm sorry.
I was just going to make just almost a whimsical comment, but when we first formed MACRMI, there was the Mass Bar Association was not part of it, and there was a lot of concern that it was really provider focused, and I remember the discussions early on saying, we're going to have a representative from the Mass Bar Association here, and we actually met Jeff, and it was he changed a lot of folks' minds that we need to do this together. And he really understood the role of apology and resolution, and not only it was the right thing to do, but that it would be a good thing for everyone involved, including the plaintiff attorneys. And I'll never forget those initial discussions. There were some people cringing in the room that we were letting Jeff in the room, and he proved us all wrong.
And I will actually say that we started working with Jeff long before MACRMI. Jeff was one of the was one of the representatives of Mass Bar Association who sat as we negotiated that consensus language a year before we established MACRMI. And he actually approached us. We were at loggerheads relative to tort reform in Massachusetts, and apology protections was one of the things that the Medical Society kept reintroducing and kept getting thwarted. And so literally he and I went out to lunch, and then we pulled together this group of 6 to think about this. And so you need a champion in any state. And he is currently the president of the Mass Bar Association, and he will be here this afternoon on one of our panels. So he has been involved all along in this. And you really need to find champions. You have to go across the aisle, as we'll say, to the adversaries and figure out where there are alliances and allegiances. And he's very much committed to the concept of patient safety improvement and not seeing errors. And he has some relatives who are physicians, and there were multiple, I think, motivations, but he has been a great and articulate advocate for this whole approach. And I would say, like we had to work with some skeptics in the physician population. Let me tell you, he had to work with some skeptics in the Mass Academy of Trial Attorneys, and to a lesser extent in the Mass Bar Association. And that's why I point out even our best practices for attorneys. When we developed those best practices, it wasn't MACRMI saying, this is what we think you ought to do. It went to the Mass Bar Association, and it went to their several councils, specific councils on various issues for approval in the process. So all I would say is the concept of bringing the parties together and getting to consensus, whether it's on legislation, best practices, regulations, whatever, is a very productive approach in the long run.
I'm Mike Annunziata. I'm a psychiatrist. Thank you for your work and for your presentation. With respect to the groups of lawyers that you've been able to put together, are any of them people who really have done a lot of malpractice work? Are they malpractice lawyers?
Yeah.
So they're not people who are now becoming malpractice lawyers as a...
Yeah. Are you referring to the list of attorneys that we have
Yeah.
online?
The list, yeah.
Yes. So yes, all of them are malpractice attorneys already. In fact, when we did this study about what kind of representation is best for patients in this process, the recommendation was an attorney, but one that was very qualified in medical malpractice area and that understood this new care program. So yes, none of them are. However, that doesn't mean that, you know, somebody who wants to become one we couldn't work with. But right now, yes, that's the way.
The second question is there a barrier for people who don't have money with this new system, that you have to pay this lawyer, presumably by the hour? If you don't have any money or you don't see yourself as being able to afford hiring a lawyer, does that lead you to the other system?
Sure. So you don't have to do an hourly rate, and it's not, you can still use contingency fees, but what we say actually in the best practices is to have a flexible and fair compensation program based on the work that you're doing. So you probably wouldn't have, you know, a contingency fee of a third if you're only going to do a couple months of work where you go to a few meetings. And so we want to basically say that there are alternative compensation agreements between attorneys and patients that may result in the care process. And so we're not saying you have to have an hourly rate or you have to pay ahead of time or any of those things. We're letting them handle how they want to do that. We're just alerting them to the fact that it is different and probably will require a different amount of work. And
Does it
therefore
seem from your
different fees.
experience to be a barrier to people who don't have
No.
money?
We have not experienced that, but
So, and please look at the best practices, because we talk about all this in the best practices about how they should consider billing and being compensated for it. And that we absolutely wanted, and Jeff is one of the people who was very strongly advocating, we want qualified malpractice attorneys to be involved on this list who are going to be representing patients.
Thank you very much.
Hi, Nicola Trupin. I'm one of the patient advisors at Beth Israel Deaconess. Two questions. One is, have you assigned, or do you, for best practices, does one person at the hospital have an assignment as the patient's contact, so that, you know, when you say you're going to get back to the patient on a certain date, that's the person, or do you rotate this through? And the second question is, there's a lot of literature, or at least conversation, about patient readiness to go through this process. How do you suggest gauging that? Because your lovely 6-month time period could be completely blown up by a patient that's not willing to even come to the table for a year. So if you would address
yeah, so I will say, to answer your first question, we do usually try to make it the same person that they contact, because that helps them to feel comfortable that they have one person that knows their case and they don't have to re-explain it every time. So that is something that we do try to do. We think that's important. For the second question, I think you're right that patients are ready at different times. And one of the findings that you'll hear about in the data analysis report is that lots of times we reached out to patients and they weren't ready, and it took longer than we thought. And in fact, that's okay. That's fine. But that wasn't what we were expecting. And so we do have a process internally to say how many times do we reach out to the patient to not make it, you know, burdensome to the patient. So we actually have 2 calls and a letter. So that's what we do. And we usually space out those calls, you know, within a few weeks or to a couple months, and then we send them a letter and say, if you'd like to engage with us, we're here and open, and this is our contact information. Because you're right, sometimes they're just not ready, and we're ready when you are.
Some patients are never ready. And we've had that experience where we've reached out, we have a plan in place, and they're really not ready. And so within, you know, it's been a year, and we continue to reach out to try to have a consistent approach. And so, you know, when I talked about those ranges, they really are ranges. This afternoon, one of the panels, we're going to talk about that issue and how it is different. And we've got our patient relations folks and our risk folks and safety folks together, and we'll get into that issue a little bit more.
Mm-hmm. And I just wanted to mention one other thing. I think that we don't know very much right now about how patients do respond in these programs. So we do have one study about how, after they've gone through these programs, what they feel like. But just those who have experienced any kind of adverse event, whether it's preventable or not, and that's an area that we really need to do a lot more research. And Linda Kenny and some others at Beth Israel have put together a grant conference to sort of figure out what that is, what we need to research, and how we can find out how we can better serve patients in that way. So.
I would also point out, just for your information, the care guideline that's in your handout is much more detailed, and it talks about the resources and the audience at each phase through here. And you'll note on the top at the right, it says 3 to 6 months plus. We recognize a lot of times you're not going to resolve this in 6 months. And we only put sort of the 6-month guide there because we had the 6 months in the pre-litigation legislation. But we also wrote into that legislation that upon agreement of both parties, that can continue indefinitely. So there's no stop point, even if if a patient has gone through an attorney, to resolve this in a 6-month time frame.
Yeah.
And there's no stop point at 6 months rigidly in this guideline that would suggest that the cases all need to be resolved by then, or we're going to litigate or do something differently. Many of them will go on for a prolonged period of time, again, because of the patient's perspective on it, and because you may not know all of the facts related to the case, or you may not know the extent of the residual or long-term sequelae of the adverse outcome.
Joe.
Oh, I think this gentleman was
Oh,
first.
Rick, were you? I'm sorry.
Gentlemen. Oh, sorry.
Giving him the benefit of the doubt.
We'll vouch for him.
When a patient gets hurt through care that is reasonably clear that it should have been and could have been better, the healing process is really clear about this. Can you talk about your experience where it's really a gray area? Or maybe even more to the point, can you talk about your experience where the care was actually reasonable and you find yourself having to talk with patients about the unintended clinical outcomes that don't warrant compensation? Thanks.
Yeah, leave it to Rick to ask the hardest question. Can I phone a friend? Those are the toughest situations, and I think where we probably have learned the most. When it's very clear, when that care protocol is initiated, when we believe the standard of care was violated, and we believe that the standard of care violation caused the harm, we sort of have a clear path. Sometimes those answers are not that clear. The standard of care doesn't appear to be violated, but it may have been. Or the patient perceives that the standard of care was violated, and we actually believe it wasn't. And that's when it becomes a much more difficult conversation. I think sticking to the principles, though, of as much as we can around transparency and honesty about what we know, I can recall cases where we've had difficulty when there was a difference in opinion of was the standard of care violated, and it actually was to our favor that we were very consistent. We actually had a lawyer, the patient was involved, brought a lawyer involved who had actually been involved with other cases as well. And when the lawyer heard our approach to this case and what our internal investigation found, and because we had been consistent over time, the lawyer actually was able to intervene to the patient and say, this probably, I couldn't do it any better in a court of law for you. This probably doesn't make sense to move forward to litigation because they're really trying to work with you. That's a big shift. But I think if we can stick to those basic principles across the board around our communication, our honesty about the investigation, and our staying in touch with folks, that's about the best that we can do.
Mm-hmm. And sometimes we will err on the side of sending it to the insurer so that they feel like there is another person outside looking at this, so that it's not just us. If they're not trusting sort of our gray area assessment of this, that somebody else is looking at it and also responding in that way. And we've also had cases where we felt like we met the standard of care, but there was a really bad outcome, and we've met with those families over and over again. They were writing down questions, coming back and asking them, and even if in the end they weren't happy about that, we felt good about the way that we were able to give them information and really tell them the truth, and it so far has been successful. So,
Joe.
First of all, thank you for the presentation, and also really well beyond that for the work that you all have done. I mean, you have really, really helped change the culture nationally as well, so thank you. I have a question, comment. I'm Joe Shapiro. I'm at Brigham and Women's Hospital. I direct the Center for Professionalism and Peer Support. One thing that strikes me and has really continued to strike me is how intensely vulnerable and unprepared clinicians are after an adverse event, particularly if there's a concern that the standard of care wasn't met or could have been done much better than it was done, or even if it's an unknown at that point. And I think, of course, that leads to all the things that we've done wrong in the past, which is not being transparent and compassionate because we're impaired, and none of us has had enough experience at doing this because, fortunately, we haven't had that many errors in our career. So the way we've handled that at the Brigham is to have a disclosure coach, which that's what I do, is a prep conversation that combines peer support for the clinicians who are often really suffering, as, you know, in some ways we should be because we feel terrible, and also don't have the, we can do grand rounds on disclosure and apology, but you're not going to remember it from 4 years ago when all of a sudden you're faced with it. And I think that prep conversation, which we didn't used to have. I mean, we felt, the risk management and patient-family relations would do the prep, but there's something about having a clinician who can hear the events and help parse out with what do we really know and what are you conjecture and what are you just speculating about, and please don't bring the speculation into the room, which is hard for physicians because we live on differential diagnoses and speculation. And I just wonder, I haven't seen that as a formal part of this, and also we have a very formal, as you know, peer support program where every clinician gets a reach out call from a non-mental health practitioner. So I just wonder, particularly around the combination of disclosure coaching and peer support, what your thoughts are about that, or where are you at with that now?
Well, first of all, Joe, thank you for your comments, and thank you for all your contributions too, nationally, to what how we now think about peer support has come a lot from you and the Brigham, and I think it's probably the last area that we as an alliance need to address is actually improving what we've done around peer support. We have formal peer support programs. We learned a lot about how to do it right, and it is it's part of the process. So as soon as we're activating the support, when we're having that communication, the peer support is being activated, the patient support is being activated. But how effective is it? I think we have opportunities to improve it. So it's there as part of the checklist. There's a program. We have tried to model a lot of what you've done, certainly at Bay State, but it has absolutely an opportunity. I will say one thing we did learn from one of the studies where we contacted patients afterwards and about their experience, how they, regardless of where the error was in the system, and this question came up earlier, the patient still wanted to hear from the physician.
Yeah, that's what our experience has
and
been.
so it all roads lead to that communication and that discussion with the physician, even though it could have been a medication error that started in the pharmacy.
Yep.
It was the physician that they want to hear from, and so coaching the physician about how to have that conversation and then supporting them in that conversation is becoming so more important.
Thank you.
Do you want to talk about the BI and how they set up their peer?
yeah, so
support
actually
group?
Joe helped us set that up.
Yeah.
So
I know.
she's the one who helped us set that up. But yeah, it's very similar to what Evan was saying. But I actually was really interested in the idea of having a clinician as part of that. I mean, a physician as part of the team to help to do the disclosure coaching. So we don't always have that. We have clinicians, but they're not always physicians. So that's a really interesting point. And we have time for one more question.
And also there was a comment, in surveying various departments, it wasn't necessarily the chief of that department that someone wanted as a peer support. So there was an opportunity to let them select who they thought would be the most supportive within their department or their specialty to help. I also would just point out, this is the ID badge backup card from BI that gives people 24/7 how to get in touch with the type of support as clinicians when something goes wrong, so that they can talk to someone even relative to the very initial discussion, even before you get into a formal disclosure. And I think the other thing to get across here, which we know, it's important for it to be that physician, that leader who was ultimately responsible, because we know not only is apology critically important for patients in dealing with their anger, but it is critically important for the providers in dealing with their grief. So the ability to be able to sit down with the patient and sincerely say, I'm sorry, and I know how this affected your life. And you heard from Trish, her perception of the physician who was able to sit down and come open. So I'm sorry, we only have time for one more question, and then
A short question.
a short question, and then we'd love to continue the discussion over lunch, and then we'll be reconvening back in this room at 1 o'clock.
I feel honored to be the last one.
It's your final word,
Last
Hassan.
word.
Dr. Rosani, a retired orthopedic surgeon, and talking about champions, I think Dr. Woodward is really our champion here in the Mass Medical Society for this whole process. I've kind of been involved with it for the past 10 years. I had a personal experience before all this started, which wasn't very good, and this is a much more acceptable environment now in which to practice medicine. I'm happy to hear about the success. We'll know more this afternoon, I think.
Absolutely.
One question I just have is what effect this is having on our liability premiums in the past, or what can we expect from the future with continued success of this type of a program?
Well, you're going to hear some data this afternoon, and there was concern on the part of insurers that not only the number of cases, potentially severity would go up. I think we're going to be able to refute that, and there's data from other states that have gone on for a longer period of time than us that have shown reduction, both at Stanford, University of Michigan, and others, a reduction in costs. But that's not the motivation. The motivation is to do the right thing, and we need to focus on that and improving the care and the patient safety. And as Rick Boothman has said on numerous occasions, the cost savings comes from the patients you don't hurt in the future as a result of your learning experience from those you've hurt in the past.
Sorry, go ahead. No, I was just going to say, now we're having lunch now. It's actually not a bag lunch. It's hot lunch in the cafeteria. So if you go out here to the right toward the lobby, the cafeteria is right past the information desk. So you have a half an hour to eat. If you can come back here at 1, Evan and Alan will be there as well, so you can ask them questions. Thanks so much.
Is it the first one?
Too crowded and other people